In our last lecture, we went over the neurologic examination in terms of how to take a history briefly, the mental status exam, speech and language testing, and now we're on to cranial nerves. And in this lecture, we'll really talk mainly about the second cranial nerve because there's a lot to say about that. We'll get a little bit into the third nerve with regards to the pupil. So of all the cranial nerves, we will say the least about the olfactory nerve, the first cranial nerve. We can see the olfactory nerve here, okay, in the olfactory mucosa of the nasal cavity. Importantly, these nerve fibers pass through the cribriform plate where they synapse here on the olfactory bulb, and then we see the olfactory tract, which remember goes back ultimately to the uncus, which is primary olfactory cortex. And here we're just seeing the olfactory bulb and tract, and there are some strial connections here that go back to the most medial part of the temporal lobe, which is the uncus, right here. So we do not routinely check olfaction on the neurologic examination because it usually isn't relevant. We'll check it if someone complains of a loss of smell or in certain neurologic conditions, such as head trauma. Because what happens in head trauma is you can easily get shearing of the olfactory nerve fibers as they pass through the cribriform plate. A rather not common thing that we see is a meningioma, which is a benign tumor of meninges, but meningiomas can grow right in this area, and so a growing tumor there may present with headaches and loss of smell. And so if you're getting that story, it would be important to get a brain scan to look for evidence of a mass lesion there. Parkinson's disease is our classic neurologic condition where there's loss of smell. More than 90% of patients with Parkinson's have anosmia or loss of smell. But the great majority of reasons for someone to lose smell are not neurologic. So if you've got a sinus infection, smokers, there are just a lot of non-neurologic reasons. So if we need to check sense of smell, we can have the patient occlude one nostril. We have scratch and sniff cards where we can ask the patient to identify different smells. If you don't have that available to you and you want to check sense of smell, you can just use, if you find some coffee in the office or something like that. Now, I just bring this up. It's a little bit funny, but it's actually practical, which is the main reason I'm sharing it, is that I learned years ago that it is a legal trick that if you ever need to go before a jury or something like that in court, that the attorney may ask, well, did you perform a complete neurologic examination? And of course, you know, you've got your whole exam there. Yeah, look at all the things I checked. And the lawyer will ask, well, did you check the first cranial nerve? And you will try to explain, well, you know, it's not really relevant in this case. And then the attorney may make a really big deal. So, doctor, you did not check the number one nerve, which is, of course, ridiculous. But apparently there have been juries that have been impressed by this argument. So I should add another reason here. If it's a legal case, we will go ahead and check sense of smell so that you don't experience that embarrassment. Okay, here is a meningioma, okay, right where these olfactory nerve fibers are traveling through the cribriform plate. So remember, headaches and loss of smell, you'd want to get a brain scan. Also just point out that smelling salts release an ammonia gas which triggers trigeminal pain fibers. Okay, this is not a way to assess sense of smell. So it triggers an inhalation reflex and has nothing to do with olfaction. Okay, we're irritating the trigeminal nerve when we do that. So most of this lecture will just be on the optic nerve, which we can see right here. So remember, we have an optic nerve and an optic chiasm, and you can't really see it here, but from the chiasm we have the optic tract going back this way. Okay, so there are four ways here to check the optic nerve. Visual acuity, which of course we've all done that with the Snellen eye chart on the wall. We also have these little pocket cards that you can carry around in the inpatient service where you can hold it up to the patient and check their visual acuity. We'll talk a lot about visual fields, a little bit about the ophthalmoscopic exam, and then at the end of this lecture we'll talk about the pupillary light reflex. All right, so visual acuity. Now, if you're seeing an optometrist or ophthalmologist, they're typically most often, interested in visual acuity as it relates to lens or ocular issues. In neurology, of course, we're usually checking this when we're concerned about something involving the optic nerve. And so visual acuity checks central macular vision. Okay, in neurology, we want corrected vision. We're not evaluating the patient for glasses. We want to know their vision with glasses on. You can do a pinhole test if someone doesn't have their glasses, like in the hospital or whatever. And so very important here to realize that only lesions anterior to the optic chiasm can affect visual acuity. So if someone has a poor visual acuity, the lesion is either in the eye itself, they got a lens or some other ophthalmologic issue, or they have a lesion of the optic nerve. So why does that occur? Well, in a little bit, we're going to talk about how vision, so this is what the patient is looking at, and this is how vision strikes the retina. You can see things that are up here strike the retina down here in green. Things that are down here will strike the upper part of the retina, and so on. And so we're going to discuss how vision, some of it stays on the same side, some of it crosses over. And let me just highlight here, I had a student draw this picture years ago, and to show that right here at the center of the optic chiasm, these are the macular fibers. And so notice that half of your macula, your central vision for visual acuity, crosses at the optic chiasm. The other half will just stay uncrossed. So why did I say that only lesions anterior to the chiasm affect visual acuity? Well, it turns out that if even half of your macula is working, having half of a macula that's functioning is enough to have normal visual acuity. You need to have lost more than 50% of your macular fibers to affect visual acuity. Okay? And so because half of macular vision crosses, half stays on the same side, you can have a huge stroke back here affecting visual pathways. Okay, but you're still going to have half of the macular fibers that crossed over. That's enough to have visual acuity, normal visual acuity. If you have an optic nerve problem, however, now you're going to destroy more than half of the macular fibers typically, and so visual acuity almost always plummets with a lesion of the optic nerve, or of the retina, or anything else in the eye. So one condition that we see a lot of in neurology is called optic neuritis, where we have inflammation of the optic nerve. Notice how this is bright compared to over here. And so this typically occurs in a condition known as multiple sclerosis. And so this is young people that suddenly have a loss of vision. It's a lot of inflammation here, so they usually have pain in the eye that's worse when they look around. It really hurts. And they have a profound drop in visual acuity because this mainly affects central vision. So trying to look at the eye chart, you just can't make out anything. And that's kind of characteristic of a lot of optic nerve lesions, is you get this central scotoma of visual loss. All right, so we can check visual acuity. The second way we can check optic nerve function is visual field testing. And this we're going to do on every single new patient we see in neurology. And the preferred method of checking visual acuity is the confrontation method. And in this method, we stand apart from the patient. We ask the patient to cover one eye. You as the examiner are going to cover the corresponding eye. And then very important, you have the patient look at your nose. And while the patient is looking at your nose, you're going to hold up fingers in all four quadrants. Well, one at a time. So here we're going to have the patient check 2, and then you're going to move your hand down here, and you'll check a certain number of fingers, maybe 5, and then you're going to hold it up here, and then you're going to hold it down here. So we check all 4 quadrants in one eye, and then we're going to ask the patient, okay, now cover the right eye, you cover your left eye, and then you're going to do the same thing, checking vision in the right eye. Okay? And so I'm going to spend some time on this because this is often a hard concept for students to grasp. So let's pretend that we are looking down on top of the eyes. So maybe you want to label on your handout. Let's call this the right eye and the left eye. Okay? And notice that the retina here is colored in this eye as blue in the temporal or outer retina, and as brown in the nasal or inner retina. And so let's say we're checking this left eye. Okay, so you have the patient looking at your nose while you have them count fingers. And notice that anything that you are going to check off to the right side in this case, so you're having the patient count fingers in the upper and lower quadrant, in this eye, vision, anything off to the right, is going to strike the outer or temporal retina of the left eye. Okay? Whereas when you're counting, having the patient count fingers over here, vision from this side will strike the nasal or inner retina. Okay? And so maybe let's just label. What we're looking at here is vision. This is what the patient is seeing. And here we're looking at the retina, and we need to follow that vision. So notice that the temporal or outer retina, vision that strikes there, travels through the optic nerve and does not cross. Okay? And so it goes through the optic tract. Here's the lateral geniculate nucleus of the thalamus, which is the thalamic nucleus for vision. And here we have the optic radiations. And then finally the occipital lobe, the striate cortex for vision. Notice that anything in this patient's left eye that comes from the left side that strikes the nasal or inner retina, this also travels through the optic nerve, but this vision crosses to the opposite optic tract, lateral geniculate, optic radiations, and occipital cortex. Okay, so if we think this through, then we can figure out what different lesions will look like here. We want to know what happens with an optic nerve lesion, an optic chiasm lesion, an optic tract lesion, and so on. Okay, so again, optic nerve, optic chiasm. Now, the lateral geniculate, remember, is that Napoleon's hat appearance. So this is the lateral geniculate nucleus. So these fibers right here that are synapsing in the lateral geniculate has to be the optic tract. And then from the lateral geniculate, we have the optic radiations going back to the occipital lobe. Okay, recall that the chiasm is about right here, and we can't see this here, but it's right adjacent to the pituitary. And then the only other part of the vision that we can see here is, of course, your occipital lobe, the striate cortex right here. All right, so first let's start. What's going to happen with an optic nerve lesion? Okay, and maybe I should have used right and left the other way in the last diagram. Now let's pretend we're looking at the brain like we do a CT or an MRI with the patient on their back, their feet coming out towards you. So here's the left eye and the right eye. So if we have a lesion of the left optic nerve, let's say just a complete lesion, like a really bad optic neuritis, well, no vision, okay, from either the temporal or nasal retina is going to get through the optic nerve. So this eye is just going to be blind, right? So we call that a monocular visual loss. So whenever someone is blind in one eye, the lesion has to be anterior to the chiasm. It's either optic nerve, or you've got a retina, or some other hemorrhage in the eye itself. Okay, the lesion just has to be right here whenever we have monocular visual loss. Okay, what about if we have a lesion of the optic chiasm? And this is completely not intuitive. You just have to understand how vision crosses to make any sense of this. But recall, what vision crosses at the optic chiasm? It's the nasal retinal vision. Okay, here in the right eye, it crosses, and here in the left eye, it crosses. So what does the nasal retina in both eyes see? It sees the temporal or outer visual field in the left eye and also in the right eye. It sees the temporal or the outer visual field. And so This is really just a classic, and I would say also relatively common board question, because not that we see it that often, but it just kind of tests your knowledge of visual pathways. And if you see vision loss like this, where it's bitemporal hemianopia. Hemi is half, opia is a visual field loss. Bitemporal hemianopia, the lesion has to be at the optic chiasm. And what is near the optic chiasm? It's the pituitary gland. So if you see a visual field like this, it means the patient has a pituitary tumor, most likely a pituitary adenoma. There are some other mass lesions that can occur in this area, but that's the most common. Okay, what if we move back now to the optic tract? Okay, so now we have a lesion here as number 3. So notice that once we get behind the chiasm, whether we're talking about an optic tract, a lateral geniculate, or an optic radiation, or an occipital lobe, any lesion behind the chiasm, because of how vision crosses, can only result in visual loss in the opposite, contralateral visual field. Okay, so if you know the lesion is in the right optic tract, the visual loss has to be on the left side in both eyes. Okay, and so whenever I'm showing you these vision, just pretend this is what the patient sees when they're looking at the screen. So notice they've lost vision on the left side, or the temporal side in the left eye, and on the nasal or medial side in the right eye. And typically with optic tract lesions, we get what's called an incongruous homonymous hemianopia. Incongruous means it's not identical from side to side. And the reason it's not identical from side to side is because in the optic tract, these visual fibers are in rotation. They're not in their fixed, settled orientation on the way back to the occipital lobe. And in general, the further we get back to the occipital lobe, the more identical the visual loss is from side to side. So if we get this kind of an incongruous appearance, then you should be thinking about an optic tract lesion. Now, later on we'll talk about the lateral geniculate, but for now let's skip on to the optic radiations. Okay, and what happens here, once we have the synapse in the lateral geniculate, the optic radiations span out over a huge range. Most of them go through the parietal lobe, but some of them go through the temporal lobe. Okay, and so lesion number 5 is showing you if we have a lesion in the temporal lobe. Okay, and because there are fewer of them here, you get less than a quadrant. Okay, so this is often called a pie in the sky visual field deficit. Okay, please cross out the word incongruent, because this is drawn as if they're perfectly symmetrical. So that's not correct. So what we see here is a homonymous. It's equal from side to side. It's superior, and it's a quadrantinopia. It's actually a little bit less than a quadrantinopia. So if you see this, the lesion has to be in the temporal lobe. And these optic radiations that travel through the temporal lobe are called Meyer's loop. And this we actually do see not infrequently. You're doing this on examination. This patient needs a brain scan. You need to figure out what's in the temporal lobe. There's a neuroscientist who used to teach this course with me. He unfortunately had melanoma that went to the brain. And for years, he would tell students about that he had this pie in the sky visual field deficit. And that was how I think they knew that he had metastasis to the brain. Now, if the optic radiations that travel through the parietal lobe are affected, you just get exactly the opposite. So it's a little more than a quadrantinopsia. Okay. Now, if we have a complete optic radiation lesion, and this is most likely what we see in a middle cerebral artery stroke, because the middle cerebral artery supplies all of the optic radiations here. So in a larger middle cerebral artery stroke, you just lose all vision to the opposite side. Okay, so if the lesion here is on the left, as the patient looks at the screen, they're going to have a complete visual loss in the contralateral or right side. So we would call this a contralateral homonymous hemianopia. Now, this visual field loss, if you ever see this, where there's some sparing of central vision, okay, yes, the lesion's occipital lobe, but we can be more specific than that. It has to be a posterior cerebral artery stroke. Okay, and the reason is, and actually most patients that I have found do not have this, but it's still a favorite board question. And the reason for that is the macular fibers back here actually have a dual blood supply. They're supplied by the middle cerebral artery and the posterior cerebral artery. So with a PCA stroke, the middle cerebral artery still supplies the macular fibers, and so you get this macular sparing. Okay, so boards love to ask about a posterior cerebral artery stroke, and for years they've had the same vignette of a patient driving a car and they keep running into things off to one side because they can't see anything over there, hitting trash cans and things like that. And for years I've told students that's a board question, but I've never really seen that scenario. And just within the last year I had a patient who actually came in because he kept running into things while driving his car because he just couldn't see any vision off to one side. All right, the third way we can evaluate the optic nerve is the ophthalmoscopic examination. And this is the only part of the central nervous system that you can actually see on the neurologic examination. And Dr. Casasa is going to go over this. You have several hours on this, so I'm just going to cover it quite briefly. Okay, but there are a number of things that you will learn about how to look at the optic nerve head and the retinal veins and arteries and the cup to disc ratio. I won't be going over that for now. We can see the macula out here. But let me just disabuse you of one notion. I remember thinking as a medical student, seeing these pictures, and I could hardly wait to do an ophthalmoscopic examination. It just looks like so much fun to identify everything here. This is not what you're going to see when you pick up an ophthalmoscope and look in a patient's eye. So here's... Maybe I'll skip forward a slide here to explain what I mean. You expect to see this, all right? But when you look in the eye with an ophthalmoscope, what you're actually able to see is a very tiny area like this, all right? So you're looking at this and you're trying to get oriented. So that's why when you do an ophthalmoscopic examination, you have to be very close to the eye and you need to really look around. Okay, you don't get a whole nice big view like this. You're going to have to peer up and down and all over the place, right? So just be prepared for that. So what are some things that we look for on the ophthalmoscopic examination? So here we have a pretty normal ophthalmoscopic examination. One of the main things we're looking for is papilledema. And later on we'll explain, why is this papilledema? What are you looking at here? But basically, increased intracranial pressure causes congestion right at the optic nerve head. We can kind of see it bulging out. Notice we lose those nice, clear, crisp margins around the optic nerve disc. So if you see papilledema, there's a mass lesion in the brain, and so we need to do a brain scan urgently. The other thing we'll look for is what's known as optic nerve pallor. Notice how the optic nerve head is very bright white here. So this is what we would see in someone who had optic neuritis, and over time atrophy then occurs of the optic nerve, and the optic nerve has this bright appearance. Okay, and then the last thing I'll talk about is just kind of an overlap between the optic nerve and the third cranial nerve. So in our next lecture, we'll spend most of the lecture just going over eye movements and talking about cranial nerves 3, 4, and 6 and how they all work together. All right, but the optic nerve and the third oculomotor nerve work together for the pupillary light reflex. So think of the pupil as being dependent, whether it constricts or dilates based on sympathetic or parasympathetic input. Sympathetics want to dilate the pupil. So if you dim the room lights, your pupils get bigger. That's sympathetics kicking in. Or if you're suddenly afraid and your sympathetics kick in, your pupils will dilate. Parasympathetics constrict. Okay? And like everything in neurology, we have these systems that are kind of in competition. So if one is knocked out, let's just say we had a sudden loss of parasympathetic input, then the sympathetics are relatively overactive and we get a big dilated pupil. Okay? Conversely, if you have a sympathetic lesion, then now the parasympathetics are going to be overactive in that eye and the pupil will constrict. All right, so in this slide, we are not talking about visual fields that we were going over before. Now we're thinking about how light impacts the pupil. So if we shine a light in the patient's eye, okay, that light travels back through the optic nerve. Okay, some of that light is going to cross in the chiasm, some will stay on the same side. So it's still going through the optic nerve, chiasm, and optic tract. But now with regards to the pupil, this is not going back to the occipital lobe, but it goes to a part of the midbrain called the pretectal nucleus. Okay, and I want you to label something here. There's actually another crossing here. This is the posterior commissure. Do you remember we labeled this on the sagittal section of the brain, and I told you it has something to do with the pupillary light reflex? Okay, so light as it's coming in crosses. Some crosses at the chiasm, some crosses at the posterior commissure, and ultimately then this light stimulates the Edinger-Westphal nucleus. And the Edinger-Westphal nucleus is the parasympathetic contribution to the third nerve. Remember, parasympathetic wants to constrict the pupil. So what you're looking at here, these green fibers are parasympathetic fibers which hitchhike along with the third nerve, goes up to a ganglion here called the ciliary ganglion, and then up to the pupil to constrict the pupil. So that's why when you shine a light in one eye, both pupils constrict equally. And they both constrict equally because some light is crossing here, some light is crossing here. So the stimulation of both Edinger-Westphal nucleus is identical, okay, in a normal patient when you shine the light in this eye and shine the light in this eye. So when you shine light in one eye, both pupils constrict to the same degree. Very precise. All right, I'm going to come back to that. Now the pupils also constrict by a totally separate pathway, which is accommodation. This is where you have the patient look to their nose, or if they're following your finger, you bring your finger to the patient's nose, and you will notice that the pupils constrict. Okay, and this requires vision, right? You're looking at they're looking at your finger as you move to the nose, and so later on we'll talk about how that works. But this pathway for constriction of the pupil actually comes from the occipital lobe. Okay, and this then goes up also into the midbrain. Okay, actually here, this is the one I meant to show. So it also stimulates the pretectal area. Remember on the last slide we showed vision stimulating the pretectal area, but this is not entirely clear, but it activates this by a kind of a different pathway that then does also activate the Edinger-Westphal nucleus. Okay, so light stimulation here stimulates the pretectal nucleus. Now this is just shown on what happens in one side, not showing you the crossing. Okay, but also activation when you look to your nose comes from the occipital lobe to also stimulate the pretectal area, which also goes to Edinger-Westphal nucleus. So that's why light or looking to your nose in a normal patient should both cause pupillary constriction. And later on in the course, we'll talk about some abnormalities where these two are sort of out of sync. Okay, so both of those are parasympathetics. Now sympathetic, this is something that a drawing I went over with you in the first year course, but it's always a top 5 question on boards from this entire course is where they like to ask you a lesion of the sympathetic control of the pupil. So just for review, there's a 3-order neuron chain to dilate your pupil that begins in the hypothalamus. Remember, the head ganglion of the autonomic nervous system. Okay, and the first step goes all the way through the brainstem. Make note of this later. Next week we will talk about lesions in the lateral medulla. And just remember that your sympathetics travel through the lateral medulla. That's very important clinically. Okay, and then these fibers synapse mainly in the upper thoracic cord. Okay, if you want to impress neurologists on rounds, you say, oh yeah, that's the ciliospinal center of budge. But I won't ask you that, but I would like you to know the area. Upper thoracic, maybe even lower cervical. Okay, and then this loops around the lung, very important, around the subclavian artery. And the second synapse is at the superior cervical ganglion. Okay, and then some of the fibers take off to supply blood vessels and sweat glands on the face. Okay, and the rest travel here along with the internal carotid artery through a very complicated route that I really don't care that you know this, but I would like you to know that this third order pathway goes to the pupil to dilate the pupil, and also very important, it supplies a minor eyelid elevator called Mueller's muscle. Okay, so that's why if you have any lesion along here, you deprive sympathetics to dilate the pupil, and so the pupil becomes smaller. And you now are not stimulating Mueller's muscle, which elevates the eyelid, and so you get ptosis. Okay, so this is the appearance of a Horner syndrome. Now, unequal pupils are very common. I think it's around 15% of the population have slightly unequal pupils. So we see this all the time. This is very obvious. You would think, well, who could miss that? But frequently it's pretty subtle. And so the first thing you should do if you're looking at a patient with unequal pupils is dim the room lights. Okay, because what happens when you dim the room lights? Your sympathetics kick in, both pupils should dilate. But if you've got a Horner syndrome, this pupil can't dilate. And so the reason dimming the room lights is so helpful is now look at this pupil. It's big. This is normal. Okay, so if you were questioning whether this is real or not, dimming the room lights will make it very convincing. Okay, this patient has a Horner syndrome. If you have someone that just has benign unequal pupils, we call that anisocoria. Anisocoria is unequal pupils. Then this pupil will dilate, and it will be still about the same difference. It'll be slightly smaller. Okay, but then if you see that, you say, okay, this is just normal asymmetrical pupils. Okay, so ptosis and meiosis are the hallmark features of Horner syndrome. We can also look for anhidrosis, which is a lack of stimulation of the sweat glands. That can be really hard to evaluate, but notice that we're only going to see anhidrosis with a lesion that's proximal to the superior cervical ganglion. So either a lesion here or a lesion here. Okay, so there's a right Horner syndrome. So what are some lesions that can cause a Horner syndrome? A first order lesion would be a stroke in the brain. Remember the lateral medulla? Okay, we'll discuss later. That's the classic one. Or something that involves the cervical cord where those fibers are traveling down. I highlighted this one because this is a frequent board question, an apical lung tumor. That second order pathway that's looping over the lung, called a Pancoast tumor. And if we have trauma to the carotid artery, where it dissects, blood dissects into the wall of the artery and it balloons out, that'll compress the sympathetics. And occasionally we can see patients, especially with cluster headache, that may have a Horner syndrome during the headache. All right, so in the next lecture, we will talk about eye movements.